Hello, I'm Amitava Banerjee. I'm a clinical data science professor at University College London, and I'm also a consultant cardiologist. I'm leading the STIMULATE-ICP study for people with long COVID across a range of institutions and also different collaborators from both private and public sector. Over to Lyth.
Hello, I'm Lyth. I'm a patient advocate and a PPI member of STIMULATE-ICP. I'm also someone with lived experience of long COVID.
Thank you, Lyth. And Mel Heightman, do you want to introduce yourself?
Hello, I'm Mel Heightman, and I'm the clinical lead for a post-COVID service at UCLH in North Central London, and working with Ami and Lyth on the STIMULATE-ICP study.
Thank you. So this is the second in a series of short discussions about evidence-based medicine in relation to long COVID. In the last session, we talked about how trials were a type of evidence within the framework, and they were quite high, if not at the top of the pyramid of evidence. So today we're going to tackle how they can help in long COVID. Mel, do you want to start off the discussion?
Thanks, Ami. I think just starting with the basics, can you explain what a trial is and why clinicians find them helpful to guide their decisions and practice with patients?
Yeah, a trial is, from the language, it's trying out different approaches to managing patients. And often we use the term in relation to drugs, but it could be in relation to investigations, it could be in relation to rehabilitation approaches. So not just drugs. And in the ideal sense, what we want to do is give a group of patients a treatment and compare them with a control who are not having the treatment. So, the control could be either no treatment or a different drug or a different treatment. And in the cleanest sense, we would want a randomized trial where people are randomly allocated to either the treatment being tested or trialed versus the control.
That's brilliant. And with the long COVID, obviously, we have been trying to feel our way with the right treatment approaches. And how would you evaluate these in a clinical trial in terms of medicines, rehabilitation? What would be the right way forward with trying to design a study like that?
Yeah, it's difficult, as I think you used the phrase a while ago, describing how we're building the plane as we're flying it. So usually we would like to give a defined treatment to a very well-defined group of people and look at very well-defined outcomes. I'm usually working in cardiology, and a heart attack or heart failure are examples where that definition of the patient group, that definition of the outcome, and definition of how we measure it in relation to drugs is more advanced or further along than we are in long COVID, where we are still defining the subtypes and the subgroups of the underlying long COVID. We're still defining, and we're further along than we were, but we're still defining the outcomes that we want to measure. And we're still looking for the treatments to test. So the best trials are based in clinical practice, in real world, because they're going to be most applicable to the most number of patients in routine practice. And we want to also try to do those trials where we're testing multiple parts of the pathway at once. We haven't got time and the luxury to test little bits and little snapshots of the patient pathway. So in the ideal world, we'd want to look at that integrated care pathway approach and look at drugs as part of the pathway.
Thank you. That makes a lot of sense.
May I come in?
Yes.
So, I mean, you mentioned that long COVID isn't properly defined or not precisely defined yet. But the same can be said for acute COVID, I think. And yet we had the recovery trial, which was world leading and discovered dexamethasone, among other things, and disproved other treatments that didn't work. This was done safely and effectively. Why can't we do the same for long COVID?
Thank you, Lyth. So acute COVID was defined by the definition was some sort of evidence of infection. And then you mentioned recovery. You were looking at people in hospital and looking at ITU admission and death. And so the definition of the disease was really binary, and the outcome was measurable in routine care. Even in simple health record systems, you hope that people are recording mortality and whether people were admitted to ITU. The difference in long COVID is we have now a WHO consensus definition. We have an agreed NICE definition, but it's based on the chronology. Within the syndrome or syndromes of long COVID, we are still working out the exact clusters or subtypes of symptoms. And so there's more heterogeneity within the initial group that we're trying to put into trials so that we can test treatments. And then in terms of the outcomes, whether it's fatigue, returning to work, looking at physical function, anxiety levels, and the type of outcomes that patients tell us are really impairing their function, these are not always recorded in routine data, whether it's in primary care or secondary care. And so how we coordinate getting that information is more of a challenge than we had in acute COVID.
Right. Thanks, Amy. So the STIMULATE-ICP includes a component where a work package, if I may, that has a trial in place for those with long COVID, trialing different drugs. It has been remarkably difficult to get the trial and the drugs involved approved, as opposed to the recovery trial. Is there any reason why that's the case? Would evidence-based medicine come in here as a possible problem that caused this delay, or is it something else?
So I don't think the framework of evidence-based medicine is a problem. I think actually it's, in this case, the nature of the disease, some of the issues around definition and of the disease and outcomes, but also understanding of the scientists, the clinicians, and the people on panels in a new disease is challenging. And this is different in those ways. And therefore, when you're thinking about which drugs to trial, if you follow the first do no harm principle, people want to have some data which is challenging in a new disease scenario before they design big trials or allow ethically big trials to happen. So I don't think that the framework is the issue, and we have in STIMULATE-ICP been able to first of all go through the funders. We're going through ethics, but before that we had to go through an independent panel to look at the drugs. And I think that's appropriate that first of all we're thinking of the safety of patients and making sure that we do science that gets you answers. The worst thing that we could do is to embark on a study with public funds which doesn't answer the question or answer relevant questions that actually end up improving patient care, either by having a negative answer or a positive answer. I think it's important to know that if we show in a trial that a drug, for example, doesn't work, that's not a failure. In fact, that can push us forward as much as finding out that a treatment works, because
Absolutely.
it means that people aren't putting faith or their own money, in many cases, behind treatments that don't work.
And health.
Yes, absolutely. And that's for neutral negative effect, negative outcomes. Yeah, if you're doing harm, then absolutely, I agree with you.
Thank you, Ami.
No problem. So today we've covered trials and how they're helping in the context of long COVID, and specifically in STIMULATE-ICP. We opted in STIMULATE-ICP for a cluster randomized design so that we could pragmatically test, as well as the drug part of our trial, we could pragmatically test whether different approaches to investigation and rehabilitation work in different geographies. And again, the idea is to find something out that's generalizable at scale to help the most patients as possible. Next time, we'll be meeting to talk about diagnostic approaches. Thanks very much.